Hello, this is Amjad al-Mandilawi from Baghdad, Iraq, presenting a session on LV angiography. LV angiography was once a standard test to assess LV function and regional wall motion abnormalities. With the improvement of other imaging studies like echocardiography and scintigraphy, its use has declined, but its role has not been abolished completely. LV angiography is best done by pictal catheter. It has a round tip and makes it safe and prevent the tip from sticking to the walls of the left ventricle. Also, it has 6 to 8 side holes in addition to the end hole, and this allows injection of dye in a uniform way rather than giving a strong jet from the tip. There are angled and straight pictal catheters. The angled one allows the catheter to take the curve from the aorta to the LV. Position of the catheter. Optimal position of the catheter in the LV is in the mid cavity, provided that ventricular ectopy is not a problem. If arrhythmia develops, then the catheter can be pulled back to lie near the LVOT in front of the mitral valve, but this position may interfere with mitral valve function and induce mitral regurgitation. So in some cases, you may need to advance the catheter to the apex. Make sure that the patient does not have LV thrombus by echocardiography. About the injection rate and volumes, usually large amount of contrast is needed in a short period of time. Power injector is required to perform rapid delivery of this amount. The injection rate and volume depend on the type and size of the catheter, the size of the ventricle to be opacified, the approximate stroke volume, and the hemodynamics. Most operators use 30 to 60 milliliter at a rate of 10 to 12 ml per second, and this means 3 seconds long injection. Higher rates and volumes are required in patients with high cardiac output and larger ventricles, and volumes as much as 50 milliliters may be needed. In a patients with hemodynamic evidence of severe LV dysfunction or a markedly raised filling pressure more than 25 mm mercury, LV angiography should be performed only after elevated pressures has been reduced. Failure to do so can lead to intractable pulmonary edema and even death. About the angiographic views, there are two standard views, and this is the RAO view with a 30-degree angulation and the LAO view with 60-degree angulation. The RAO view allows one to assess the anterior, this is the anterior, and the apical and the inferior wall of the left ventricle. Also, it allows to assess the severity of mitral regurgitation, and in this case, more angulation up to 40 degrees is required to assess the mitral valve. And this is a living case of LV angiography in the RAO view. The LAO view, 60 degrees, allows assessment of the septal integrity. Here is the septum passing from the aorta from the LVOT up to the apex, and this is the septal wall, and also the lateral and the posterior wall. Adding a cranial angulation makes the septal part being seen in a profile, and this with the cranial angulation is important to assess for ventricular septal defect. And this is a live angiography in the LAO view. Some operators exploit the coronary catheter to do LV angiography and make some measurements, especially the Jetkin-Rice catheter, when it inadvertently passes into the LV during attempt to engage the RCA. This thing should be done carefully and is generally not advisable, as the information it gives might be not complete. And also there is a risk of myocardial staining and even perforation if power injection is used. Other catheters sometimes used, like the NIH catheter, which has side holes without end hole, and this decreases the risk of injury to the myocardium. Here we can see an LV angiogram done by an NIH catheter. The catheter used for LV angiography can be used to obtain information about hemodynamics, particularly the LVEDP. When we do that, proper measurement is done at 50 millimeter per second speed and a lower range of a pressure measurement. Dampening should be proper. This view shows under dampening with overshooting of the pressures. This can be corrected by injection of a small amount of diluted contrast. In a patient with ischemic heart disease, we usually look for regional wall motion abnormalities, and the range varies greatly from normal LV angiogram to severe global hypokinesia. This patient has near normal angiogram. One may argue that there is septal hypokinesia of the anterior wall. This is the anterior wall when compared to the inferior wall. This patient has a critical lesion in the LID. In another extreme case, we can see severely dilated left ventricle with global hypokinesia. This patient has his LID totally occluded. Another patient with a three-vessel disease where the LID is totally occluded, the circumflex totally occluded, D1 critical lesion, and the RCA has distal critical lesion. His angiography again shows global hypokinesia with severe LV dysfunction. Here we can see some localized hypokinesia and disorganized movement of the left ventricle. A patient with total occlusion of the RCA and the normal left system, we expect to see hypokinesia of the inferior wall. You see this part, the inferior part, is hypokinetic while normal motion of the other ventricular wall. While in another patient like this one, we can see a localized aneurysm. This female patient presented with acute chest pain, ECG changes, and elevated cardiac enzymes. She was rushed into the cath lab and the coronaries were normal. The diagnosis can be achieved at the same session by LV angiography, and it showed global hypokinesia with a sparing of the basal parts consistent with stress-induced cardiomyopathy. This was proved later by echocardiography. Here we can see at the presentation hypokinesia globally with near normal contractility at the basal part. 5 weeks later, the patient returned completely to normal. LV angiography is a useful tool to assess the severity of mitral regurgitation. And here we need a larger volume of contrast, and it's important to achieve a steady state in the LV without VT and without multiple ectopics. Usually MR is assessed in an RAO view, and you may need to increase the RAO angle to 40 to 50 degrees, both to keep the mitral valve in perspective and the ascending aorta and the descending aorta out of view. This case shows severe MR, where the density of the LA is seen to be more than the LV after achieving a steady state. It's also clear that there is a hugely dilated LA with reversal of flow into the pulmonary veins. LV angiogram can be used during closure of paravalvular leak although TE should suffice in such condition. This example shows moderate to severe MR, although the assessment is hampered by the development of VT. This is another example in an RAO view where there is paravalvular leak. An extreme LIO or lateral view may be used to assess the MR as seen in this case. This is the LV and this is the mitral valve and plus blood passing from the LV into the LA, which is a posterior structure, through the mitral valve. The exact location of the paravalvular leak is of course determined by TEE. When it is necessary to do LV angiogram in the presence of a prosthetic valve, a catheter can safely be passed into the LV, but make sure that the pictal catheter is withdrawn after passing a wire. LV angiogram can show post-MIBSD. The best view is usually the LIO view with a cranial angulation. It shows the septum in a profile. Here we can see the septum as a white line separating the LV, and contrast is passing through the septum into the RV. LV angiogram can be used to diagnose hypertrophic cardiomyopathy, both the obstructive and the non-obstructive type. In this case, we can see vigorous contractility of the left ventricle with LVH, but usually this is an echo diagnosis. This is a still picture of the same patient, shows the classical sign of ballerino foot. But what is more important in HOCM is the hemodynamics that shows dynamic LVOT obstruction with the pressure tracing from both the LV and the aorta. This is the same patient, had a one channel measurement showed pullback gradient of 55 mm of mercury. The LV tracing shows what is called the Broken-Barra phenomena. After a PVC and a long pause, there is increased contractility of the LV with an increase in the preload. Both these conditions will lead to an exaggeration of the gradient across the LVOT. Another case with ECG changes and normal coronaries. Look at these ECGs with biphasic T wave and deep T wave inversion. And this is another case. And this is another case. Oftentimes, coronary angiography is done to these patients and are reported as normal without a hint toward the cause of the ECG changes. We think that LV angiography may even be more important in patients with normal coronaries, because some cases with apical HCM, the diagnosis is missed by echocardiography. This is the angiogram of the patient with apical HCM. You can see how the hypertrophy involving the apical part with almost complete obstruction of the lumen. And this is another case. And these are two more cases, so that you can be acquainted with such condition, which is more frequent than we realize. Sometimes we do not need a catheter to be passed into the LV to do the LV angiogram. In this case, doing a coronary angiography opacifies the left ventricle. Here is the RAO view in the same patient, and this is the LAO view. It shows good contractility, and this is what is called the coronary cameral fistula. And thank you.